question there.
My name is Romy Mattis from Switzerland. You quoted the Swiss cohort. I just wanted to clarify. In my memory, the increase of hepatitis C, HCV, was among MSM.
Yes, it was MSM.
I didn't hear that, but so
well, it was on the slide. I didn't
so
say.
if you say we should vaccinate or we should control, you speak about MSM.
No. Yeah. I speak, it was, I put, I don't know if the increase was MSM, and I specified that I was surprised to see that in IDUs it was going down. It was increasing in MSMs, and specifically in those with syphilis who had 4-fold more risk of acute hep C than MSM without syphilis. So I think we should monitor specifically MSMs.
Thank you for this great story. If you had been using TDF in the first regimen, would you have been waiting for viral load to decrease before vaccination with the risk of forgetting it?
Again, I'm really not, I told you, I'm not an expert, but I think in a high-risk patient, you should not. In a high-risk patient, you should not. Probably, that's what actually the EACTS is noted. You should probably use a double-dose vaccine strategy in those with lower CD4, in those with higher age, and I think we should have done it. And if it doesn't work, you revaccinate when he is low viral load, undetectable, and high CD4. I think this story of waiting for CD4s go up, undetectable, it's not good in high-risk patients.
I mean, just, I think the authors, in the paper by Kees Brinkman's group, the authors conclude at the end that you need not even check hepatitis B vaccination status if people are on TDF. Would you agree with that?
No.
Okay.
No. I think that is something I learned. I was surprised that there is a debate around this. And even if it's not debate, even in their paper, 14% of people still, I mean, it's not completely, even in their paper, which is, I mean, with all the biases, even in their paper, people on TDF still get acute hepatitis B. So I think we should, yeah.
So Giovanni, you've shown in your cohort that as patients grow older, there seems to be changes in treatment, more dual therapies or monotherapies. Have you looked specifically what are the drugs you more commonly switch away from in your older patients? Here.
And so, of course, as you can see, you can imagine that within a dual or monotherapy, there's just some drugs that are used and not others. Of course, monotherapy to us means boosted PI or boosted or unboosted PI with 3TC. I would like to stress the fact that actually the recent publication by Modat in which actually atazanavir, ritonavir plus 3TC was even superior, that standard triple therapy in this study that has been conducted in Italy in which I participated. And so this is for monodual. Let me say most of the dual therapy are built up with integrase inhibitors, okay? Yeah. And so maybe combination of integrase inhibitors plus, for instance, boosted, let me say, PIs, or even actually we are using more, especially in some specific population, also Maraviroc within this special population, because we are, let us say, somehow concerned of the NAFLD, the issue that is affecting our patients, and that there are quite interesting studies about the use of Maraviroc in patients with liver steatosis. Actually, we brought up, let us say, some experience regarding the fact that the level of liver steatosis is so much connected with many metabolic conditions, not just within the liver, but outside the liver. And so, of course, it's quite difficult, but my point is that actually we are missing studies in which the endpoint goes beyond the virological results, and we are missing studies in which the condition of frailty and disability is the entry criteria so that to address some special drug regimen. What so far we have data regarding the effectiveness of registrational trials in patients above the age of 50, but actually this means nothing, because if you go to see who are the patients who are above 50, above the age of 50 in these clinical trials, most of the time they are perfectly healthy individuals, because of the fact that exclusion criteria actually make you get out from all the patients with chronic condition that they may already be present if you are old. And so once again, I think that lots need to be rewritten regarding the management of antiretroviral therapy, having properly designed trials in which frailty and disability is the entry criteria and the quality of life is the end point beyond undetectability in this clinical trial.
Okay, and I have a question for Darren too. You know, when you see, you know, all these needs that the patients have, how is your system to prioritize? Because it's nice that you have that clinic, but in other clinics that we don't have so many resources, how do you prioritize?
In what context, sorry?
In your patients, you know, in your aging patients, you have all these rehabilitations, goals, and...
So maybe to explain the service in the sense that patients are referred to me by their clinician, and that could be absolutely anybody. So it could be their nurse, it could be their doctor, it could be their psychologist. And the key thing at the minute, it's about identifying the need, and there's no kind of screening tools that are used for that. And I think that's the primary issue, that actually we are not identifying disability effectively amongst people living with HIV, and therefore determining who requires rehabilitation. And I think that exactly what Giovanni is saying around kind of measuring frailty and those things, I think could be effective tools. But at the minute, it's reliant on people recognising the need for a referral to physio, and therefore that's where the prioritisation comes in. When it comes to my interventions with people, the prioritisation is dependent on the person that I'm supporting. It's their priorities. So it's very much goals-based interventions.
I think I'd be very happy if, given all the things we've discussed, people would not go home with the notion that they should do whatever they can just for all the associated morbidities. I think we have to realize that whatever we do, keeping people virologically suppressed is the prerequisite for all the other things. So we should never switch away to dangerous regimens which might jeopardize this long-term perspective of the patients just because some other toxicity occurs that might be handled otherwise.